Very good morning. I am Dr. Santosh. Last class we had discussed regarding thyrotoxic goiter. Today we shall discuss regarding thyroid malignancy. Introduction. Thyroid, as we had already discussed, it is shield-like 10 to 25 gram organ, which is pyramidal in lobe. Remnant. It's a remnant of thyroglossal duct. T3, T4. Okay. From usually produced from the gestational age between 8 to 20 weeks. Okay. Thyroid nodule is a discrete lesion in the thyroid gland that is radiologically distinct from the surrounding parenchyma. The population incidence is 20 to 76%. This thyroid nodule is formed by TSH stimulation, and this thyroid nodule about 10 to 15% are malignant. Okay, what is the risk of malignancy in a thyroid nodule? There are various factors which play a role in the increased risk of malignancies. First being the age. Okay, there are bimodal distribution. Patients age more than 70 years and also children's between less than 14 years. Okay, they are more prone. Childhood nodules, that is 3 to 4 fold higher risk for malignancies. Childhood, when the child is exposed to radiation, especially the head and neck cancers. So here the nodules have increased chance, that is 33 to 37% chance of malignancy. Okay, other than that, then 18 FTG PET positive lesions, that is in that up to 30 to 50% there is a risk of malignancies. Okay, 5% for other imaging incidentalomas. Other than that, the family history of thyroid cancer, particularly the first degree relatives, personal history of genetic syndromes, that is the MEN2 and familial papillary thyroid cancer, FAP. FAP I will be discussing in detail, and about regarding Gardner's and Cowden syndrome. Physical examination findings, which are fixed, hard, solid nodules, cervical lymphadenopathy and vocal cord paralysis, you can see on physical examination. Okay, what are the syndromes that are associated with thyroid cancer? The clinical and genetic characteristics of familial thyroid follicular cell carcinoma susceptibility syndromes. This include the papillary thyroid carcinoma that is associated with the papillary renal neoplasm. Okay, and familial non-medullary thyroid carcinoma, familial thyroid tumors with cell oxyphilia. Okay, and familial FAP, that is familial adenomatous polyposis. Other than that, like the Cowden syndrome, in which the PTN gene is there, and this Carnase complex 1. Okay, and in case of this papillary thyroid carcinoma with papillary renal neoplasia, that is you can see that there is an involvement of chromosome 1. Okay, and in case of the papillary carcinoma, renal carcinoma, you know the involvement of chromosome 3. Okay, here it is the 1q21, which is associated with the papillary renal neoplasia, which is autosomal dominant with partial penetrance. Okay, familial non-medullary thyroid carcinoma, familial thyroid neoplasm with cell oxyphilia. Okay, the most important are the FAP, you know, that is the familial adenomatous polyposis. Okay, which is associated with the colon malignancies. Okay, so here you can see that the papillary thyroid carcinoma, there is an increased risk, 10 times increased prevalence associated with colorectal malignancy, ampullary carcinoma. In Cowden syndrome, you can see that there is an involvement of you can see that it is in this, there is an involvement of follicular and papillary thyroid carcinoma. Okay, and in Carnase complex, you can see there is a papillary and follicular. Okay, in case of FAP, you can see only there is papillary thyroid and there is no involvement of follicular. Okay, whereas in Cowden's and Carnase, you can see both papillary and follicular thyroid carcinoma. Investigations. Okay, radioactive iodine, when it is indicated, is that is which is associated with suppressed TSH. Okay, and this it indicates the radioactive iodine scan, which indicates that it is a hot nodules. Okay, in which there is FNAC is not needed. Okay, then high resolution ultrasound, which shows microcalcifications, hypoechoic, hypervascular, and irregular bordle or taller than wide nodules are seen on ultrasound. Okay, and FNAC. Okay, in that, what are the components, sonographic features? What are the components that we see is solid nodules, mixed cystic and solid nodules, and or if it is a simple cyst or suspicious cervical lymph nodes. Okay, it's a sonographical features that you see, and reporting, that is reporting system, in that thyroid between 1 to 5, thyroid thyroid 1 is the non-diagnostic, composed of up to 10 to 15%. Okay, 1C is the cystic non-diagnostic. Thyroid 2 is the benign, that is in this the most common, that is 60 to 80% belong to this group, benign. Of that, follicular lesion or neoplasm consists about 10 to 20% in thyroid 3. Suspicious for papillary thyroid carcinoma, thyroid cancer, it is seen in 2.5% to 10%. And thyroid 5, which is the sure shot, it's malignancy, that is composed of about 3.5% to 10%. Okay, where do you do FNAC? Okay, in case of malignancies. Okay, and treatment pathway for nodules. Okay, when there is a thyroid nodule, okay, you confirm whether it's a euthyroid. Okay, you do have an FNAC. Okay, on FNAC, if there is suspicious of benign, suspicious or malignant, okay, you can, so sure shot, that is when it is malignant, obviously you subject the patient to thyroidectomy. What is in case of benign? Okay, when there is compressive symptoms, okay, you undergo that patient to the consider it for thyroidectomy. In case of suspicious nodules, okay, you do thyroid lobectomy and subject that patient to frozen section after thyroid lobectomy. And if it proves to be a malignant, then you undergo total thyroid lobectomy. Okay, if it is considered to be malignant, then thyroid lobectomy, okay, you consider. Okay, and this FNAC, we already discussed that it can't differentiate between follicular adenoma and follicular carcinoma. Okay, it needs, that is an FNAC, you can't differentiate because you need a capsular vascular invasion to diagnose the malignancy. Okay, which is not done. So okay, so that is why biopsy is required. Okay, indeterminate lesion, that is molecular profiling. Okay, if the risk is less than 5%, then observe. Risk factors for carcinoma thyroid: childhood exposure to radiation, that is even 0.6% gray increases the risk, and it never returns to normal. Latency period is between 3 to 5 years, usually between 20 to 40 years. Okay, the patient he can develop this carcinoma, and the most common that we observe is the papillary thyroid cancers. Then familial history, especially the syndromes that we discussed, the familial medullary thyroid carcinomas. Okay, and thirdly, that is the thyroid lymphoma. Okay, especially the mild non-Hodgkin's lymphoma associated with Hashimoto's disease. Coming to pathology. Okay, what are the most common? That is the most common is the differential thyroid cancer, in which you can see there is a follicular cell origin, papillary carcinoma and its variants, and follicular carcinomas. Okay, that is the variant of follicular is the Hurthle cells, or 3 to 5%. And other apart from differentiated thyroid cancer, which is 90%, you can see there is a parafollicular cells arise from parafollicular cells, which lead to the medullary thyroid carcinomas, about 5 to 9%. And least is the anaplastic and poorly differentiated carcinoma in 1%. And the more rarer are the papillary thyroid micro carcinomas, are defined as PTC with maximum diameter of less than 1 centimeter, may be amenable for observation and follow-up. Coming to what is this TNM staging. Okay, TNM staging, you can see that T0 is no evidence of primary tumor. T1 is that when the tumor lesion is less than 1 centimeter. T1B is between 1 to 2 centimeters. Okay, T2 is that between the tumor size is between 2 to 4 centimeters, and T3 is more than 4 centimeter, confined to thyroid or or tumor of any size with minimal extrathyroidal extension. Okay, T4A is the one which involves the extrathyroidal tissues or subcutaneous tissue to invade the subcutaneous tissue, larynx, trachea, esophagus, and recurrent laryngeal nerve, or intrathyroidal anaplastic carcinoma. Okay, is included under this T4A. T4B is one which encroaches and ensheaths the vessels. It invades the prevertebral fascia and encases the carotid artery and mediastinal vessels. Okay, or extrathyroidal anaplastic carcinoma comes under T4B. Regional lymph nodes, how do they divide? That is the central. C is the central compartment, lateral cervical nodes, and the upper mediastinal. Okay, in that N1A is the metastasis to level 6. Okay, that is those are the Delphian nodes, that is pre and paratracheal or pre-laryngeal nodes. N1B is that when it metastasizes to lateral nodes, that is unilateral, bilateral, or contralateral cervical nodes other than the level 6. Okay, which also includes the level 7 nodes, superior mediastinal nodes. Distant metastasis, the M1, M0 is one, there is no distant metastasis. M1 is the distant metastasis. Stage grouping. Okay, in this papillary, how do they group under this papillary and follicular carcinoma? The age is very important. As we know, the age more than older age has a higher risk. So in thus the age under less than 45 years, they are under low risk. Okay, 45 years and above. Okay, and in that there are 4 stages. Stage 1, 2, 3, 4. Again in 4 A, B, C. Okay, we have seen already like T3 lesions, that is up till 4 centimeters. Okay, and there is no involvement of the thyroid, that is extra, and in stage 3 there is involvement only of the extrathyroidal tissues that we discussed. Okay, and stage 4A, which includes both N1B. Okay, that means that which encases the vessels. T4B and T4C. Okay, is also in where the T4 stage 4C is one where there is a metastasis. Same as well for medullary carcinoma and anaplastic carcinoma. Okay, in the new version of NCCN guidelines, you can see that the T3A, okay, where we have said it is more than 4 centimeter. Okay, again it is involved in this. They have told that T3A and T3B. T3A is one with the tumor more than 4 centimeter limited to thyroid. T3B is one which is the gross extrathyroidal extension, that is the involvement of strap muscles. T3B, that is sternohyoid, sternothyroid, thyrohyoid, omohyoid muscles. Okay, and similarly everything there. Okay, T4 and others other than like lymph node extension and the distant metastasis remains the same NCCN guidelines. Okay, coming to what are the prognostic scores, you can see that there is age score, AMES score, and MASIS score. Okay, age score, that is the age, tumor grade, tumor extension, and tumor size, ages. Sometimes in examination you can be asked what is the expansion of ages. You should be knowing that. The high risk is one which has score of more than 4. Okay, I'll be telling the components in the next slides. AMES score, age, metastatic disease, extrathyroidal extension, and size. Okay, which was designed by the Leher Clinic. Okay, these are worst prognostic indicators included in this criteria, AMES criteria. Okay, and male sex, older age, major capsular invasion for follicular carcinomas, tumors more than 5 cm in size, extrathyroidal extension of tumor, and distant metastatic presentation. What is the third is the MASIS score, metastasis, patient age, completeness of resection, local invasion, and thyroid and tumor size, which is divided by Mayo Clinic. Okay, low score is considered less than 6. Okay, in that AMES, ages, AMES, and MASIS score. Okay, survival, the prognostic means how much is the survival, is the ages score is that when the score is less than 3, there is a 99% survival. Okay, and when the survival and the score is more than 6, and you can see that the prognosis is less, up to 13%. Okay, AMES, as I was telling, age, metastatic disease, extrathyroidal extension, and size. Okay, in that the other factors are the old patients, that is with associated capsular invasions. Okay, high risk are those with distant metastasis. Okay, survival, low risk is better. Low risk they have 99% survival, high risk have 61% survival. Okay, and massive scoring in that prognostic score depends on the, as I've told, less than 6 we have good prognosis, 99% good prognosis, and more than 8 have a low survival, that is up to 24%. These are the prognostic scores. Okay, coming to genetic prognostic markers. Okay, V600E BRAF mutation is the initiating mutation in 40 to 50% of papillary thyroid cancers, follicular thyroid and Hurthle cell carcinomas. Flow cytometry DNA aneuploidy, that is there is an increased tumor related mortality. These are the genetic prognostic markers. Okay, pathology. Okay, among all the that we have already discussed, that the types of malignancy in pathology, that the papillary thyroid malignancy, follicular thyroid malignancy, anaplastic. Okay, among this the papillary thyroid carcinoma is the most common. Okay, presence. Okay, how do you identify this? The presence of papilla, that is the follicular variant has no papilla. Okay, so this is the identification of papilla, presence of papilla. Diagnostic feature is the orphan anenuclei, contain nuclear grooves and internuclear pseudo inclusions. Okay, how to differentiate is, this is the multifocal and multicentric, and they have lymph nodal metastasis. So papillary thyroid carcinoma, they have more lymph node metastasis. Coming to what is follicular thyroid carcinoma, the true follicular thyroid is a tumor comprising about 5 to 50 to 10% of the thyroid malignancies. Okay, it is in the non-endemic goiter areas. Okay, and there is a capsular vascular invasion needed for diagnosis. Okay, hematogenous metastases are more common than papillary thyroid. So you can find that there is a hematogenous metastasis in follicular thyroid cancers. So in papillary thyroid carcinoma, you can see the lymph nodal extension, whereas in case of follicular thyroid, you see there is a blood spread. Okay, so what is this Hurthle cell carcinoma? Hurthle cell is a variant of this follicular cell neoplasm, also called the Hurthle or oxyphilic cell Ashkenazi cells. 65% of these tumors have more than 4 cm are found to be malignant. Malignant HCC, that is the Hurthle cell carcinomas, contain at least 75% Hurthle cells. Treatment of differential thyroid cancers. Okay, what is the treatment? Is the total or near total thyroidectomy with central node dissection, routinely done by Mayo for all types of differential thyroid cancers. Post-operative, that is suppression of aldoxin. Keep TSH levels less than for high risk and below, and between 0.1 to 0.5 in case for low risk. What is this? Radioactive iodine ablation with iodine 131. Okay, other than this malignancies, this thyroidectomy that you do for malignancies, radioactive iodine ablation also plays role. Where does it indicated? Mandatorily, it is when the tumor is more than 4 cm extrathyroidal extension or unstimulated thyroglobulin, that is more than 5 to 10 nanogram per ml, or when there is distant metastasis. Along with the surgery, that radioactive iodine ablation is a must. Okay, avoided. Where does it avoided? It, if all below are true, that is, it is avoided if, okay, when there is a classical papillary thyroid cancers. Okay, where you can do only surgery. Okay, avoided. Okay, and T1 lesions, you need not do thyroid ablation, radioactive iodine ablation. Okay, and in case of intrathyroidal, only intrathyroidal, unifocal, okay, multifocal less than 1 cm, unstimulated thyroglobulin less than 1 nanogram, or no anti-globulin antibodies, anti-thyroglobulin antibodies. Radioactive iodine ablation, selective use if is there. Selective use you do only in case of this T1, T2 or more lesions, or high risk histology or lymphatic invasion, node metastasis if there is a node metastasis, and multifocal, that is more than 1 cm at one focus, and margins positive, and unstimulated thyroglobulin levels less than 5 to 10 nanogram per ml. Radioactive iodine ablation. Okay, the dose that you use for low dose iodine 131 therapy is the 13 millicuries. For metastasis, you increase the dose up to 150 to 300 millicuries. TSH must be more than 30 ml international units per liter for 131 iodine scan or ablation. Post therapy scan, you do it after 1 week after radioactive iodine ablation for metastasis. Iodine 131 therapy can cause secondary malignancies. Okay, apart what are these are the side effects of this radioactive ablation is that it can cause second malignancies. Most common are the bone and soft tissue tumors, colorectal, salivary, and leukemias. What is this thyroglobulin? Okay, autoantibodies to thyroglobulin, which occurs in 25% of the patients with thyroid cancer, and 10% of the with general population, will falsely lower serum levels of thyroglobulin levels. This TSH suppressed thyroglobulin should be less than 0.5 nanogram per ml, represents absence of clinically relevant diseases. Rise in thyroglobulin levels with negative whole body scan, that is in the FDG PET CT. Okay, you can see there is a rising thyroglobulin with negative whole body scan. Okay, in case of advanced differentiated thyroid carcinoma, okay, advanced, when do you call it as advanced differential thyroid cancers? When it is refractory to radioactive iodine ablation. Okay, treatment is with tyrosine kinase inhibitors, that is sorafenib and vandatinib. MEK1 and MEK2 inhibitor selumetinib induced iodine incorporation into previously radioactive iodine ablation tumors, allowing a therapeutic radioactive ablation dose to be delivered to metastatic lesions, okay, which lead to reversal of the loss of radioactive iodine avidity. What is this anaplastic carcinoma? Okay, apart from this papillary and follicular, you can see third one is the anaplastic carcinoma, which is a undifferentiated carcinoma from the follicular cells. Okay, median overall survival is less than 5 months, because by the time the patient is presented, already there is a metastasis. Okay, 50% distant metastasis at presentation. Okay, older age, that is the female preponderance. Okay, and the stage 4, that is 4A and 4B, it is limited to thyroid. 4A means that is limited to thyroid only in 10%. 4B is extrathyroidal or the regional spread. Okay, IVC metastatic. Okay, treatment for 4A is the surgical resection followed by radiotherapy and chemo, and in case of 4C, when you do only palliative, that is the hysterectomy to avoid the compression of airways. Coming to medullary thyroid cancers. Okay, this medullary goiter with amyloid was described by Jacquard. Okay, 80% are sporadic. Okay, and only 20% are familial. Of this, 60% have somatic red proto-oncogene. Okay, mutation limited to C cells. 50% of the nodal mets at presentation. Okay, 5% will have distant metastasis. Most common is the lung and bone and liver. Okay, this about the medullary thyroid cancers. In that, the familial component, as we had discussed, that is the 80% are sporadic, and of that only 20 to 25% are medullary thyroid cancers, familial causes. Gain of functional RET mutation, C cell hyperplasia later on medullary thyroid cancers. It is multicentric and bilateral. The involvement of this multiple endocrine neoplasia. Okay, MEN2A, MEN2B involvement, there will be there in medullary thyroid cancers. MEN2A is the most common. Medullary thyroid cancer will be there associated with pheochromocytoma with primary hyperparathyroidism. Okay, whereas in case of MEN2B, it is the more aggressive, that is the medullary thyroid cancer with pheochromocytoma, and there is no primary hyperparathyroidism in case of MEN2B. Okay, whereas others like the medulated corneal nerve fibers, morphinoid habitus, and mucosal ganglion neuromas will be there. Familial medullary thyroid cancer, only medullary thyroid is in at least 2 generations. Other than that, MEN4B, MEN4 and MEN-X is there. Okay, what is this genetic characteristics of familial medullary thyroid cancers? Okay, obviously this familial medullary thyroid is a component of this medullary thyroid cancers. Okay, MEN2A, there is, as I told, medullary thyroid cancer along with pheochromocytoma and parathyroid hyperplasia. MEN2A, as I told, there is no hyperparathyroidism. Okay, there is involvement of MEN2A with pruritic cutaneous lesions. Okay, MEN2A with or familial medullary with Hirschsprung's disease. You can see that MEN2A or familial medullary with Hirschsprung's disease is seen. MEN2B, you can see there is a medullary thyroid cancer, pheochromocytoma. There is no involvement of this parathyroid. Okay, there is no involvement of parathyroid. Intestinal ganglion neuromas will be there. Okay, characteristic of morphinoid habitus. MEN2B is a most aggressive prophylactic thyroidectomy you do in infancy, the treatment. Okay, and MEN2A with familial medullary thyroid, you do prophylactic thyroidectomy at 5 to 6 years. Okay, medullary thyroid cancer mutations. Level 3 has the highest risk, level 2 is the intermediate risk, and level 1 is the low risk medullary thyroid cancers. And these mutations with this differential numbers. Okay, what are the markers for these two medullary thyroid cancers? This is the CEA and calcitonin. Calcitonin, when there is more than 400 picograms per ml, you look for metastasis. Calcitonin doubling time, you look. Treatment of this medullary thyroid cancers. So total thyroidectomy with central compartment dissection in all patients. Okay, when there is a lateral neck dissection for selected patients, when other than the level 6 nodes are, if it is involved. Then persistent calcitonin elevation, that is imaging to rule out distant metastasis. PET only for 78% sensitive. Localized neck dissection, repeated neck dissection may be done. External beam radiotherapy, unresectable symptomatic disease, painful bony mets. Okay, adjuvant role questionable. Okay, systemic therapy, tyrosine kinase inhibitors for advanced diseases, vandatinib per day, that is 300 milligram. Okay, targets VEGF receptor, epidermal growth factor receptor, and RET, can cause sudden death by torsiorous depointers. Okay, vandatinib, cabozantinib for advanced diseases. The least is the one, that is the thyroid lymphoma. Okay, 50% have underlying Hashimoto's lymphocytic thyroiditis. 1 to 5% have thyroid malignancies. Okay, 10% have B symptoms of lymphoma. Older age, that is usually this thyroid lymphoma, they are of old age, the 7th decade, female most common, and the most common type is the non-Hodgkin's lymphoma. Diffuse large B cell lymphoma is the most common, and rest are the mild lymphomas. Okay, 50% are stage 1E, confined to thyroid. Total thyroidectomy with radiotherapy without chemotherapy is the surgical treatment, Okay, 45% of the stage 2E, okay, in which the thyroid with cervical mediastinal nodes are involved. Okay, and only 5% will present in the stage 3E and 4. Other stages, that is chemotherapy, that is in stage 3, you give this chemotherapy with radiotherapy. Okay, 3 cycles, that is 3 cycles of chemotherapy with and 6 cycles of chemotherapy alone in case of stage 2 and 4. Childhood thyroid cancers, the high relation to radiotherapy exposure. Most common is the papillary thyroid carcinomas, in 90% of the cases. Higher incidence of node and neck metastasis. Aggressive treatment with total thyroidectomy with central neck dissection. Radioactive iodine ablation only in high risk groups or gross residual disease, that is to avoid non-thyroid second primary tumors. Okay, and here ends the topic. Okay, and thank you for the patient hearing. Okay.